Good afternoon or late good morning to everyone if you're in another time zone. Welcome to our closing session of the Health Literacy in Action Conference. I'm Cynthia Bauer, Director of the Horowitz Center for Health Literacy at the University of Maryland School of Public Health and co-convener of this conference with the Institute for Healthcare Advancement. So please take your virtual seats. We'll get started in just a minute. Okay, we're ready to kick off our afternoon session, and I am so pleased to be bringing you our closing keynote speaker. It's a real pleasure for me to introduce Professor Kathleen Hall Jamieson. She is the Elizabeth Ware Packard Professor of Communication at the University of Pennsylvania's Annenberg School for Communication. She is the Walter and Leonore Annenberg Director of the Annenberg's Public Policy Center, and she is also the Program Director of the Annenberg program at Sunnylands. She is also the co-founder of factcheck.org, which we will hear about this afternoon, and its sister site, SideCheck. So welcome, Professor Jamieson. We're very pleased to have you here this afternoon to talk to us about misinformation as a threat to health literacy.
Thank you, Cynthia. It's such a pleasure to be with you. I remember my 16 years at the University of Maryland very fondly. And so this has for me an additional piece of special meaning. Let me ask Gary Gaiman, who's helping with the slides, to please advance the next slide. I'm going to argue that overall confidence in science, scientific institutions, and the spokespersons from science remains high, but we've got some worrisome indicators, and confidence is lower among conservative media users. That can be a problem. Social media exposure can also be problematic, but we shouldn't let the mainstream off the hook. They get some things wrong too. How do we deal with information? And we can look at some examples. So that's basically the structure. Let's open the first slide. Overall confidence in science is high. This isn't our data, but it's national data. It's consistent with what else is known elsewhere, including other work that we've done. Next slide. This is from our data. Right before the pandemic, we did an Annenberg Science Knowledge Survey, national probability sample, in order to find out what does the public know and think about science. Next slide. Perceptions of scientists' competence exceeds perceptions of their trustworthiness, and those exceed perceptions of their shared values. Now, I'm bookmarking this because if you don't think someone is trustworthy and don't think they share your values, then their competence actually could become a liability because they could competently act in ways that you wouldn't think are appropriate. In particular, like would be appropriate for you. Next slide. But overall, the public is confident that scientists provide trustworthy information. Still, that 25% is a little worrisome. Next slide. The public's confidence that scientists offer unbiased conclusions about their work varies by field. And you still see high percents, but some areas lower than others. Next slide. And when you break it out by ideology, what you see is a partisan difference. Take a look at these two in particular. Now remember, that's before COVID. We actually aren't measuring COVID science yet. We will in a moment. And you can tell climate, well, that's been polarized as a topic. And genetics, that's covering the GMO debates in which you've got folks on either side who don't really like what the science necessarily is saying when it's ideologically inconvenient for their point of view. Next slide. Majority still, nonetheless, see scientists as neither liberal nor conservative. A plurality believes scientists can overcome their biases. Again, you'd like those numbers to be higher because if you're going to see something politicized, then your perception that the scientists in an area have an ideology. And as a result, you identify them as scientists with that ideology. That's easier to conspiracize claims about those scientists and about their areas of inquiry. Next slide. Consistent with high trust, most consider science a reliable way of knowing. Next slide. And they believe science is more reliable now than it was 2 decades ago. And let me pause here because there was about 1.5 to 3 years ago, a meme that took hold in part because scientists were finding problems in their own areas and correcting them. But the meme said, science is in crisis, science is broken. And the implication was that the science now isn't as good as it once was. Well, this suggests that whatever else was going on with those statements in headlines, often offered by scientists, the public was still thinking, no, it's better now than it was then. And that's actually reassuring because the science in crisis premise got a reasonable amount of traction, including in mainstream press. Next slide. There are, however, sustained current attacks, and now we're stepping into the COVID era against spokespersons for particularly medical or health science. Let me give you some examples.
But first tonight, he is the left-wing New Green Deal socialist's most cherished public figure. Longtime government doctor who is often wrong, but never in doubt. Anthony Flip-Flop Fauci is once again back in the news.
Much of what Fauci said about this virus, the drugs that could treat it, and the measures that could be taken to slow the spread was untrue. He knew it was untrue.
I think Fauci at one time was one of the most important scientists in the world. And I'm watching his decay. I mean, people worry about President Biden. I worry about Fauci in terms of his cognitive impairment.
Well, he's been there for 40 years, probably 39 years too long, but he controls all the funding. So people are deathly afraid of him.
Now, I've already bookmarked that the percent that sees scientists as liberal or conservative is a little higher than you'd like to see. In fact, you'd like to see that they don't perceive that at all, because science is a method that should stand apart and yield results regardless of the ideology of the person who's engaged in the method. And science's culture of critique should uncover instances in which those biases have gotten in the way of findings that are reliably generated by a method. But what you're seeing here is Sean Hannity is marking Dr. Fauci off as a liberal, playing on that reservoir of belief that those scientists are basically ideological and that some of them can't overcome their biases. That was the earlier slide. The last piece that I showed here was alleging something different, where there's also a vulnerability that I'm going to show in a moment. Dr. Fauci controls the funding, and as a result, he controls what we see of the science. Only a problem if you think that people who control funding bias the outcomes. Only a problem if you think those who are funded engage in suppression of findings that are inconvenient for their funders. So that premise also is sitting there. It was sitting there before COVID. And we're going to see that it can be exploitable because of the nature of the conspiracy theory surrounding COVID. Next slide. So now we're speaking about current data. Now we're jumping through COVID. And you're seeing Annenberg surveys that were conducted in August from 2020 through September 2021. So in general, the confidence in Dr. Fauci remains high across that period. That's good news. Sustained attacks, overall confidence is high. But let's look under the figures. Next slide. Oh, I was going to I have healthcare providers in first. Apologies. We want to just stress here the importance of messengers who aren't the national health figures. In general, how confident are you that your doctor or nurse or your primary healthcare provider is providing you with trustworthy information about the means of preventing and treating COVID? In general, people are very confident in their healthcare provider. In fact, that confidence is higher than the earlier slide. So what that suggests is that the strategy that is now being used to disseminate information, for example, about vaccination through local providers is right on target. Next slide. Have you discussed the COVID vaccination with a healthcare worker? Oops, healthcare provider? Not as many as one would like. If you've got confidence, we'd like that you would have the discussion with them. Well, we'd like the discussion even if you don't, because at least it provides accurate information. But what that means is there's a lost opportunity to leverage the credibility of those whom we deal in our own communities who are giving us healthcare to communicate to us good information about COVID and about vaccination in particular. Next slide. When you talk to a person, they're supportive of vaccination. So we're missing a channel of potential influence for those that don't have that engagement. Next slide. And overall, I want to make sure that in talking about disinformation, I'm not creating the false impression that everybody is disinformed about everything, because they're just not. In fact, if you step back and looked at all of the knowledge that the public has gained during COVID, you'd be astonished by how well the public health institutions and their experts and the scholars who are involved in that process have done, and the local healthcare providers. Do you agree or not? It's safer to get COVID-19 vaccine than to get COVID. 3/4 of the American public. Incidentally, that's about the percent that we've got vaccinated right now, fully vaccinated right now, or at least within that range. So that's the good news. The good news is that would be a really good number, except that it isn't a high enough number to prevent the spread. Because when you're dealing with vaccination and contagion, relatively small proportions of the public can still carry the infection. And given the nature of COVID, those who've already been vaccinated can to some extent too. Next slide. So there are some worrisome indicators. We saw them on the early slides pre-COVID. We're going to look at some more now because I'm going to argue that they're being used to build conspiracies about public health, and that's interfering with public health literacy about messaging that matters. So let's look at some of the worrisome indicators. That first slide, by the way, was about something good. The messages have gotten through. First, the perception of the frequency with which replication fails. Well, we don't know how frequent it actually fails, but I just wanted to put this up because in general, the public doesn't understand replication at all. When the public sees a headline that says replication of something failed, they think the second study was necessarily right and the first study was necessarily wrong. Well, it could just be the reverse, or there could be flaws in both, or they could both be right. They just specified their variables differently. But what this speaks to is what happens when the public health officials say, healthy people don't need to wear masks. And then about a month later, they say, oops, it'd be a good idea if healthy people did wear masks. Healthy meaning people who don't appear to have symptoms. When they said it the first time, the second time, they'd learned about asymptomatic spread. And as a result, the advice changed. So if you think scientists may not get it right, and then it's found out in replication, the replication fails, it's instead of seeing science as something that checks its own premises and regularly updates, the danger is people will read that and say, oh, well, those scientists must not have been competent, when that's not what's going on at all. The culture of science, the norm of replication, is what protects us from all of the limitations in our method and our studies and all of our human biases. Next slide. Perception of the frequency of fraud. This one is really worrisome because fraud can't be good. I can't create a construction in which somebody would say, great, we've got more fraud. Next slide. How often do the scientists exaggerate the significance of a study's findings? 34%. You notice how those percents are starting to creep up on the negative indicators. Next slide. Perception scientists do whatever it takes to get grants and publish, even if it means cutting corners. Now we're starting to speak to that last statement in the slides in which a US senator suggests that Fauci controls the funding and as a result, what it is we know. There was a disposition to believe that that was happening, that scholars would suppress findings, would tailor findings that preceded the pandemic, because remember, this is January 2020 data. Next slide. Well, scientists publish findings that run counter to the interests of the funding organization. Almost 60%. Now, why is this worrisome? If you believe those things before COVID, and now someone says, Anthony Fauci and the pharmaceutical industry control the funding that the researchers get. And as a result, they corrupt the research process. So the researchers only publish things that the pharmaceutical industry wants to find. As a result, cures are being suppressed. You're now in the middle of a conspiracy theory. And when you accept that conspiracy theory, that acceptance increases the likelihood that you will not mask and you will not vaccinate. So conspiracy theories that have conspiracized the funding process in science can basically undercut the trustworthiness, perceived trustworthiness of those who are making positive, good health recommendations to us that if we take will increase the likelihood that we can get this pandemic and put it behind us. If not, longer haul. Next slide. Confidence is lower among conservative media users. So I've pointed to the worrisome indicators. Well, the worrisome indicators are being capitalized on by some in conservative media channels. And here, when I'm showing Fox News, it's the opinion hosts in the evening. It's not the Brett Baiers and it's not the Chris Wallaces. But in those programs, you have potentially captive audiences with a backup stream with substantial social media exposure. And those sources, in some cases, are offering messaging. I showed you some about Dr. Fauci that are playing through the worrisome indicators to create arguments that would minimize the likelihood that you would vaccinate and mask. So let's take a look at confidence is lower among conservative media exposures. those with conservative media exposure. If you look to the bottom slide is mainstream. And this is trustworthy information about, and Dr. Fauci is the person who's posited to be giving it. Social media, less, but still that's respectable. The big platforms have done a reasonably good job. And I know that this is heresy to say, but they've done a reasonably good job at interdicting the problematic information once it starts circulating. They have trouble catching it as quickly as they should, and they have trouble blocking the secondary and tertiary circulation. But at least they're trying, and they have the massive audiences. And we think that we're seeing some of that effect across time as the signal in our surveys about their role, their associated role in increasing the likelihood that people hold misperceptions begins to drop relative, for example, to other sources, such as conservative media, such as very conservative media. Conservative is media outlets such as Fox News, lower. Very conservative. This is the telegrams of the world. These are basically social media sources that traffic routinely in conspiracy theories. And those conspiracy theories have as one of their core premises, Dr. Fauci is a liar who is corrupt and engaged in untoward activities. And then the conspiracy theories spin off, sometimes in collusion with Bill Gates, sometimes with George Soros, sometimes with the big telecom companies, sometimes being responsible for things in relationship to 5G. But he has a lot of power and he's in league with big tech, with big pharma. And as a result, what you hear, you can't trust. Next slide. There's also an effect out of, this is now mainstream conservative media exposure, sources such as Fox News, in your willingness to take hydroxychloroquine during the period in which it is being investigated. And as a result, the scientific community does not know whether it will be effective against COVID and does not know whether the risks will outweigh the benefits. After this study was concluded, the data came in, clinical trial data came in to say it's not effective for hospitalized COVID and the risks outweigh the benefits as a treatment for hospitalized COVID. But we're in this interim period, and what you're seeing is the red dots are Republicans self-identified, the Democrats and independents are identified as blue. As you move, remember, that's their ideology. As you move toward conservative media reliance, that is more total exposure just to that conservative ecosphere, you increase the likelihood that whether they are Republicans or Democrats, they are willing to take hydroxychloroquine, which at that point is an unproven drug. Now, the reason we want to tease that out is because you want to know what the effect is of Donald Trump saying, try it, I'm taking it, it's good, and the effect of exposure to a conservative ecosphere, which is saying it's a miracle, it's a cure, take it. And the medical establishment is telling you not to because they have a self-interest in having you wait until we get the vaccine where they can make a lot of money, or a self-interest in marketing other kinds of treatments. So what this tells you is that ecosphere has a capacity to shape perceptions. It also has a capacity to polarize the public and medical health area, the arena on specific kinds of topics. That speaks, by the way, to how we ought to be addressing this as a problem. We ought to be increasing the likelihood that we have voices in conservative media, voices everywhere, but also in conservative media, that are speaking for science and not permitting a message imbalance to sit in place in favor of a non-science driven point of view. We know in communication that message imbalances matter. And essentially by ceding that whole terrain, by saying, I'm not going to go there, we increase the likelihood that what people hear there is only one side. And so I applaud the public health community for putting PSAs in those venues, and it's experts for going into those venues to ensure that the message of public health is being heard there on consequential topics such as masking and vaccination. And you ultimately would like the public health message to be heard on things like hydroxychloroquine when we know and can say it's not effective for hospitalized COVID and risks outweigh benefits. And you'd like the message to be right on ivermectin. The message on ivermectin at the moment is, please don't take the veterinary version. There are no tests of purity and the dosage would be all wrong. Yes, it's on label for some human uses, some very narrow human uses, but we're studying to determine whether or not it has a use against COVID. So the right thing to do right now is to say, wait, let's wait and see what the science says. It's a difficult message to convey when people are anxious and somebody's telling them that they're a cure, but We could find that there are benefits. We could find that the risks outweigh the benefits. But right now, all we can say is we should probably wait and see. Let's wait for the science. Next slide. Ongoing conservative media use intensifies COVID-19 conspiracy beliefs. Next slide. Ongoing conservative media use is associated through belief in conspiracy theories with reduced intention to vaccinate, reduced intention to mask. And that's the reason we should worry about it in a public health context. Sometimes there are forms of disinformation in media spheres, and while any disinformation at some level is worrisome, it's not immediately consequential in anyone's lives. When we're dealing with public health information, it can be consequential, and that's why we should worry. Excuse me, next slide. Social media exposure can also be problematic. Next slide. This is early research that we did during the pandemic. We looked at misinformation about efficacy of certain kinds of treatments for COVID and also conspiracy theories. And we found very early that there was a social media association. By the way, across time, it's been less so. And that is the point I made earlier. Still there, but less so. Next slide. And finally, I don't want to let mainstream media off the hook. Next slide. This is the J&J pause. And these are some of the headlines. Next slide. What the mainstream media doesn't do well, among the things the mainstream media doesn't do well, is calibrate relative risk. Part of the problem is the headline is just a headline, and all it's got in its arsenal are words. And the word rare doesn't of itself communicate how rare. So if I wanted to write the headline on the likelihood of blood clots from the J&J vaccine based on what we now know now, not what we knew during the pause, we know more now. And I want to say, I want to verbally represent it, but I'm constrained. It's going to be verbal. I'm not going to use a visual. I would say very, 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 very rare. But my headline can't do that because the whole page would be taken up with the varies. So some constraint here is in the nature of headlines, and it's also in the fact that we don't have good words to convey the relative rareness of something. Now, sometimes the headlines will say extremely, and that helps a little bit. But first point is there's a problem here within the way in which headlines conventionalize. My recommendation is that we visualize the prevalence level and that we put the visual as close to the headline as we can. So that what we do is get people to say rare, and they look to the visual and they say, oh, only 2 dots out of all of those dots? Well, that's a lot more rare than I would have thought just reading the word rare. And it means I'm not thinking it's 1 out of 2, for example, or 1 out of 5. Next slide. So let's look at the J&J pause. Here are the dates. We fielded a survey that overlapped with those dates. But the first thing we did in that process was we searched every headline. And there were almost 3,000 of them. And we got interquarter reliability, Krippendorf Alpha, Krippendorf on the faculty of Annenberg School, if I get to brag. And what we found was, and we separate out the mainstream headlines as well. And then I'm just showing you the mainstream because there wasn't a big difference between mainstream and overall. Mainstream is ABC, NBC, CBS. We found that they featured the pause. They didn't say it was unconfirmed at that point. It was. The result was unconfirmed. They mentioned clots. They mentioned adverse. They occasionally mentioned specific numbers of cases, which does help to ground the difference a little if you can keep the denominator straight, but headlines don't. Rarely occurred, and safety virtually didn't occur at all. Safety frame didn't occur virtually at all. A safety frame would say, by the way, that the monitoring system caught the possibility that there was a side effect and stopped long enough to find out, was it prevalent, in whom, what would we do about it if it actually did exist? That would be a safety frame. The risk frame says, it's there. Next slide. So we've got a probability sample. We're running at the same time that we've got the pause. We've got 2 days. We're on the back side at that point, but we're in the field during and a little bit after. Next slide. So here's what happened. First, there is in the lay understanding of media effects the idea that either the public knows everything instantaneously or the public never gets anything. And the truth is the public has rapid uptake on salient topics. And something that's a salient topic, whether or not there's a side effect of a vaccine you're likely to take or have taken, and vaccines in general, salient topic. We've got hundreds of millions of people at this point have taken. At that point, millions of people had already taken. So the first thing is you had high uptake. Now look at how quick this is. This has just happened. We're just sitting there in the field. Wow, they've heard or read. Well, maybe they don't get it right when they hear or read something. Surprise, the public is a lot smarter than that. Next slide. Most of them got that, it was J&J. So we have an attentive public. Now, what happens when you have an attentive public? Well, the messaging frame really matters. And the headlines were consistent in their messaging frame. The messaging frame was a risk frame, not a safety frame, and a frame that often was mentioning explicitly an adverse event or the blood clots. And in that context, your signal is one that says, wait, stop, let's have some hesitance here. Something's going badly wrong. Next slide. Based on what you've heard or read, how safe do you think the vaccines are? And this is comparing Moderna and Johnson & Johnson. Next. How likely would you be to take Moderna, Johnson & Johnson? Next slide. Just your best estimate, are you more likely to experience a severe blood clot if you get infected with COVID or you take the J&J vaccine? Now notice how many people are not sure there. And notice how close those two numbers actually are in terms of getting infected and taking the J&J vaccine. Next slide. Just your best estimate, which of the following is more likely to occur? Dying from COVID if you're infected or dying from a severe blood disorder. That tells me you've got about 20% of the population that's getting something grossly wrong and about 30% of the population that doesn't know. So what have we managed to do in a very short period of time? People have miscalibrated the risk of COVID versus dying of COVID versus dying of the blood clots. So this pause wasn't about dying of the blood clots. It was about blood clots and then what else might be going on. So what we see is mainstream. My survey results are only of people who said that they were reliant on mainstream. This isn't national probability. This is people who said they were reliant on mainstream. So where did they say they're getting their information? Well, that's what I showed you for the headlines. And here's the likely effects. Next slide. Media is associated with heightened perception of the risk. So if you rarely or never use the mainstream, you're sometimes used, or you use it all the time, that's your differential rate of belief that a severe blood disorder is more likely if you take the Johnson & Johnson vaccine. Next. Dealing with misinformation. My view of the world in social media looks like this. You've got all those deceptions out on the left. The platforms can block it or downgrade it. And recently, all three platforms came on board to saying they were going to block consequential misinformation about vaccination. They should have done it earlier, but you've now got Google, YouTube, Facebook, Instagram, and Twitter all saying they're going to block. Well, that should make life a lot easier. You've got fact checkers to correct if it gets through that screen or it comes from someplace else outside social media. And the fact checkers in partnership with Facebook, and myfactcheck.org is one of them, do post up corrective content through a link to the misinformed content once it's been flagged by Facebook. And it's flagged by Facebook in part because the fact checkers have fact checked it to say that it has some element of it that's false or problematic. But you've got other corrections. So a knowledgeable person could find it online within that person's circle of influence and correct it interpersonally. Or you could, when it gets to the community, and you hope at that point it doesn't, you could have individuals, families, and friends inside the community who are able to correct it. But most importantly, they can create a context in which the norms are such that the norms are pro-vaccination and masking. And so that norm will minimize the likelihood that if it gets there, it will be translated into action. So that's my view of how this works. Now, let me move more specifically into some things that I think are important to remember as we try to figure out what we're going to communicate to those places and people that are inside that defense system. The first is we should be communicating in gists. We should communicate knowledge preemptively. My second point, We should use a safety frame rather than a risk frame when risk is at issue. And we should use trustworthy sources who communicate credible messages in a credible manner. Now, I'm not telling anybody in this audience anything new. All I'm doing is illustrating with some things that I think have done it reasonably well, and pointing to some things that we've tried to do. Next slide. First, the GIST literature is rich, sophisticated, and important. This is largely the work of Valerie Reyna, and it looks at the way in which we come to represent what we know cognitively in the gist of what we've been exposed to. And it tells us such things as, you can give people numbers and relative numbers and everything else, but they're going to draw out of it a fundamental set of good, bad, relatively good, relatively bad, higher, lower. They're going to come to a bottom line in which most of that stuff just disappears. They will process that verbatim detailed content at the same time that they draw the gist, or the gist comes through to them. But what is likely to be retained is the gist, the bottom line. Now, the message for us should be, that means we should be communicating that bottom line explicitly in our texts to increase the likelihood that that's the bottom line that they justify or they draw out as the gist of the messages that they're hearing. And part of what that means is, in the media realm, and I see the question on the screen, that one of the things we ought to do with our fact checks is ensure that our bottom line is in our headline, because it's our headline that's most likely to be seen in the corrective context of the disinformation on the platforms when they flag it and they link to our content. So those people who are fact checking and they justify in their headline, and I'm going to give you an example of just in just 1 minute, Melina, thank you for the question. When they justify their headline, the deception in the headline, what they basically are saying, the bottom line we want you to take away is the deception. Well, no, it's not. And even if they say false, and then the bottom line is the deception, they still have reinforced the deception. They haven't told you what the bottom line is. So let me give you an example of a bottom line. Getting infected with COVID is far more risky or dangerous to you than any small risk associated with getting the vaccine. That's a gist. It's a bottom line. Masks help prevent transmission and infection. That's a bottom line. I can give you all the studies, I can give you all the details, but at the end of that, your takeaway is going to be, masks work or masks don't. That's a gist. And we sometimes, because largely those of us who are in the academy, we value information, we value detail, we value facticity, we value high levels of disclosure, and we should. That's how we talk to each other and how we certify our knowledge and how we check each other's knowledge. But in the process, we sometimes forget that people who don't know what we know have real trouble navigating that. And even those of us who know a lot don't remember most of that. We carry away from it a kind of bottom line. And sometimes in our scholarship, we forget to tell people what the bottom line is. And someone who wants to polarize our science comes in and takes one sentence out of context, basically says that's what it meant, and as a result draws a misleading inference about what we actually found. One implication of Valerie Reyna's research is we should justify our own scholarship on consequential topics that will ever move into public so that somebody else can't misjustify our basic underlying concepts, our basic underlying knowledge for a mass public. And if you want to see an example of how that happens, look at the mistake the CDC made when it put one sentence up that said that 6% of the deaths were caused by COVID alone. Intact sentence. You could literally lift that sentence up and say the CDC said it. You could put the whole thing up and pull that up and say CDC said it. That was then taken to mean by the community that wanted to discredit the severity of COVID and discredit the CDC, and had been arguing for an extended period CDC is exaggerating the extent of COVID and the deaths are being exaggerated. And what it's taken to mean is the rest of those people who died or are being attributed to COVID didn't die because they got COVID. So what that meant was a statement that to the CDC meant, well, you're reading it in context, obviously. The rest of these were comorbid. There were all kinds of other conditions there. And that could mean your comorbidity made you more likely to get COVID. You got COVID and died. COVID gave you an outcome. As a result of that outcome, you died, but you wouldn't have gotten the outcome and died unless you had COVID. All that's lumped into that other figure. That wasn't structured in a way that drove to the bottom line gist. CDC, love you, That was a big mistake. So once you say we should think in terms of GIST, it has implications for us as scholars, us as public health messengers, us as fact checkers, and us as human beings, because we'd like to get the GISTs right. And here's why. Because not only do GISTs increase the likelihood that messages are remembered, but also Raina's more recent work shows that increases the likelihood that the basic GIST content is communicated to others, particularly online. They did a study of Facebook virality and found that when the knowledge, and this was public health knowledge, it was about vaccination. When that knowledge was reduced to a GIST, the likelihood that it was spread increased. So if I have one big takeaway from this body of literature is we should be asking every time, and this goes back to my time at the University of Maryland, where I was in 1984. Do any of you remember Sarah Peller and Where's the Beef? And Walter Mondale saying to Gary Hart, where's the beef? Well, my question isn't where's the beef, it's where's the gist. What is the gist and where is the gist is for me a bottom line now as a communicator, particularly on consequential information, particularly consequential knowledge, particularly in the public health realm. Next slide. So do I practice what I preach? Play, please. So what should we worry about? Communicating in advance. The bottom line, the gist, vaccination is safer than getting the virus. And you can see there, I was here, but there I sound a lot meaner than I hope I do now. Next. Gists can be visual. Ideally, gists are verbal and visual. You're reinforcing. But remember when I said, what do you do about this problem the headline writers have about rare? You drop the visual in that demonstrates how rare or how prevalent. Next slide. Visual. This is the visualization that says masks help, not masks work. Masks work is actually deceptive because people hear it as they work categorically. Masks help prevent transmission infection. That visual says that. It says help. See, it doesn't completely block the spray, but it does block it compared to the same person, same structure without the mask. Next slide. I love this one because all it tells you is that there's a distance between it. It doesn't tell you how far. So we can start to say, so what's missing in the visual gist? And by the way, the verbal gist was wrong too when we said that was social distancing. We don't want people to socially distance. We want them during COVID, even when we are in quote unquote lockdown, to be in contact regularly with everybody who loves us and we love. We want, in other words, social contact, physical distancing. Next. We want to communicate knowledge preemptively. Next. My favorite example, it's not our research, it's somebody else's, so I get to really say I think it's fabulous. Play, please.
I'm Ron Keyes. I'm a retired Air Force general. People ask me all the time, why does the military care about climate change? The answer is, it affects national security and our ability to do our job. The military doesn't see climate change as a political issue. We see it as a threat to our country. We have at least 19 vital bases around the world affected by rising sea levels. We're already experiencing significant flooding at Norfolk Naval Base. It doesn't end there. If you look at Langley Air Force Base's runway, it's only about 8 feet above sea level, with only a rise of a few inches. A simple nor'easter pulls in and all of a sudden, we're underwater. There's a second front. In almost every part of the world, drought, floods, and severe storms are triggering mass refugee migrations that we are called upon to respond to, while devastated areas can become breeding grounds for terrorists. We need to protect ourselves from these risks. Part of the solution is developing clean, renewable energy. For the military, this is about our ability to keep our country safe. The facts are in. Humans are causing climate change, and the impacts are already happening. We can do it. We're already doing it. Now we need the rest of the country to join us. This has to be everybody's fight. Learn more about climate change and what you can do to help. Go to newclimatevoices.org.
The gist, climate change is human caused and the effects are already with us, parens, and we're experiencing them in ways that potentially endanger our national security. We need to act now. Now, what I like about this is preemptive knowledge is it's not saying there are people who believe, and it's not a refutative structure. It says Think of this from the perspective of a general, someone who, if you are conservative, more likely to doubt the anthropogenic origins of climate change, you are more likely to trust. Think about this from the perspective of national security, an issue more highly valued by those who are conservative, parens, less likely to believe that climate change is anthropogenic and less likely to believe that we need to act to respond to it now. So start in a place in which you trust the source and you're coming through a topical lens that for a person may be new, that lets him lay down the knowledge that you could then see migrating into all of the other places where the knowledge is going to be highly polarized. And you're talking in more traditional terms with more traditional advocates. Also, his manner is calm. Doesn't sound as if he's proselytizing. This is just a lovely piece of messaging, and it culminates in a gist. Next slide. And here are the effects. And credit to the scholars who put it together and the organization that put the message together. Next slide. Through a safety rather than a risk frame. Next slide. And when you think about a safety and a risk frame, we ought to be looking for the places that we can use this kind of frame and the places we can put our preemptive knowledge, as well as the places in which we can lodge our digestive gists. And I want to remind everybody that we should be looking for every place that we can get advertent exposure. And I'm going to show you our fact checking, but inadvertent exposure really matters too. So here's advertent. You come to our website or you're a subscriber, please do, no cost, factcheck.org. It's wonderful. I found it in 2003. It's the thing I'm most proud of, other than having 2 great children and a wonderful husband. You come to factcheck.org, and before we let you come into the body of our story, we're going to tell you, how do we know vaccines are safe? How were the vaccines tested? It's preemptive knowledge. If you know those things, you're less susceptible to deceptions about the safety of vaccines. You're less susceptible to perceptions that this was just too fast. They just didn't do what they needed to do. So we're going to lay down some preemptive content, justified, to minimize your susceptibility. And we're also then going to perform the fact-checking function. Next slide. Through inadvertent exposure. If you're driving around in your car in Philadelphia and you're listening to our most popular radio programs in our market, you're going to hear something like this once a week.
Let's separate COVID-19 facts from fiction. Fiction, the speed of vaccine development compromised safety. Fact, the speed of vaccine was due to multiple factors and didn't require skimping on safety. The technology has been studied for years, and scientists had experience with other coronaviruses. Early testing stages were consolidated and companies began manufacturing the vaccines earlier than normal thanks to the government taking on the financial risk. Get the facts on COVID-19? Visit factcheck.org.
Now remember, we're on the popular radio stations. You're not going to turn off your popular radio station where you love the music, you love the talk host, just because somebody's dropping 30 seconds of rapid talk in on you, because you love the venue. So we are basically inadvertent exposure. Advertently, you're there for that host or for that music. But we're going to give you this, and in these stations across our market, you're going to hear this up to 250 times if you paid attention to everything. On your favorite show, you might hear it 5 to 7. You're, in other words, getting it at a level that would, according to the marketers, reasonably penetrate and pick up memory. The question is, have we gotten gists there that you would hold on to? Next. Also, we've got in-person moments that we're not taking advantage of. This is really the tragedy of the last year. Imagine a year and a half ago, if somebody were to say to the public health community, I'm going to give you 350 million plus chances to talk to the public where they're going to have nothing else to do but listen to you if you're effective. More than 350 million chances. I'm going to have them actually sitting there. They're going to be sitting with you, and they're going to be worried about a topic you're going to give them information on. That's the safety monitoring period after those people have gotten their vaccines. And what did we give them? We gave them a little thing that said, watch out for these side effects. And they went off and they looked at the side effects and they said, okay, and they started working on their mobile phones. Instead, we're giving them a brochure, and the brochure has gists in it. And we're hoping they're going to read the brochure, they're going to pick up the gists, here are some of the gists, and they're going to carry them home because gists increase memorability and sharing, and they're going to talk those gists when their family and friends say, well, so how is the vaccine? We know you're more likely to talk about novel experiences. Vaccination is pretty novel for most of us. You're more likely to talk about your vaccination. We're going to arm them with their gists, with their preemptive knowledge, and we're going to hope they share as a result. By the way, our brochure also has a QR code to get you back to factcheck.org. And the other thing our partners in the public health community are giving out along with the brochure is information on where the next vaccination clinics are, so that when they come back to those vaccination clinics, they can bring their friends. Next. Through targeted messaging and mass media, we have not done all that we could to tailor messaging very tightly to the specific kinds of concerns that are accurate and justified. We've spent a lot of time dealing with the concerns that are inaccurate, but we know community by community where legitimate reservations exist. And in the Black community in particular, we know there's a legitimate reason to distrust the medical establishment. Here's a response.
We are Black American members of the National Academy of Medicine,
the premier health science organization in our nation.
We are scientists,
physicians,
healthcare professionals,
and public health experts.
We are your neighbor, the person sitting next to you in church. We are members of the Black community.
Trust in government does not come easily for our community. Too often our health has been ignored and even abused.
As health professionals, we understand the science.
As members of the Black community, we understand your distrust.
But COVID-19 is very serious.
And it has a devastating impact on our community.
We are confident the research was done correctly.
We support the COVID-19 vaccine, and we encourage you to get vaccinated.
Do it for our community.
Do it because we should not tolerate one more preventable death.
Sponsored by the National Academy of Medicine.
Now, the takeaway gist, the thing that this should drive into consciousness, the mental representation gist, the gist of the message, should be people who are experts and are part of our community, who share our skepticism and our reservations, say you can trust this vaccine, and this vaccine will prevent needless death. So trusted people say trust vaccine. Only matters if you reach the audience that is susceptible to the reservation with a source that is credible for that audience. Thanks to Comcast, iHeartRadio, and Facebook, this messaging was targeted to reach the Black community in venues in which we already know it is gathered inside those media structures. Next slide. And Gary Gaiman, by the way, who's the person who's helping with the slides, is the one who edited this video. Through online engagement, this is the last piece. Remember my science defense shield? I don't want to give up once it's out there and circulating. I don't want to give up when the fact checkers haven't managed to get it and correct it. I want people online, and that's all of us, when they see a deception, to go online and start to talk from their preemptive knowledge in justified form as trustable sources into that stream. Here's Jack Gorman. Some of you who are in the psychiatry field know he's Gorman of Gorman and Nathan, one of the prime psychiatry texts in the history of the field in the last 30 years. But here he's just Jack. And he's talking back to a stream about a problematic claim in the Tucker Carlson media stream out of the postings that Carlson gets lots of extra views for over and above the audience that tunes into him in real time in a cable channel. He gets an awful lot of additional traction in social media. And Jack basically is talking to people about what they don't need to be afraid by. And he's talking about how rare the events are. So remembering that we are always health communicators, and no matter who we are, if we have health knowledge and we see someplace that we can intervene just to change the message balance in a tone that's respectful and not adversarial, we ought to feel some obligation to do it. Next slide. But the problem is, you can have all of these things in place in that you can have gists, you can have preemptive knowledge, good baseline preemptive knowledge. You can be using a safety frame. If you're not a credible source delivering it credibly, you're going to undercut the message. And there's some stuff online right now that I hope is only seen by a very, very narrow targeted audience that is already vaccinated. And this is one such piece.
From the ER. You should get vaccinated. Yes, of course, you can still get COVID-19 even if you're vaccinated. The same way you can still get pregnant if you use birth control, and the same way you can still die from a car accident if you use a seatbelt. But that doesn't mean you're not going to use the birth control or the seatbelt. The vaccine is not a cure, it is a layer of protection, up to 95%. 95% is not 100%. They've been telling you this since day one. You can still get COVID-19 even if you're vaccinated. We didn't kill the virus. It's still very much there. But the vaccine helps protect you from developing severe symptoms from the virus, so you don't die. It also reduces the risk of you spreading the virus, so other people don't die. Did you think about that? Of course not, you selfish. There are people around the world who would give up their left nut for a vaccine shot, and you're worried that it's some government scheme to microchip and track you? They're tracking you through your phones. Get your vaccine shots.
Right. But don't get your vaccine shot from him because he's really scary. And I don't trust smartasses who are wearing medical garb. I'm not sure he's actually a doctor. That's just me. So in summary, overall confidence is high and a lot of good health information has gotten through to a lot of people, and the public health community ought to be proud of that. But there are some susceptibilities to us as messengers, to science as messengers, to scientists as messengers, and they're being capitalized on and exploited. We need to minimize the likelihood that we have those vulnerabilities by making sure that every place we can, any problems in our system are corrected, and communicating clearly as well about how our system corrects itself and how it protects the integrity of its knowledge, even in the face of human bias and occasional human duplicity and occasional human fraud. Those worrisome indicators are being scaffolded up into conspiracy theories that increase the likelihood that people will reject public health expertise and that they will not mask and will not vaccinate. And that's problematic. But we have some good ways to deal with misinformation. And in that arsenal, we have a capacity to create and deploy gists to audiences in need of them preemptively through a safety rather than a risk frame, using trusted sources who communicate credible messages in a credible manner to the audiences that are in need of hearing them. With that, I'd be happy to take your comments and your questions.
Kathleen, thank you so much for, I think, just really providing such a grounded explanation of this kind of general feeling people have had about confusion, right? I think that's the number one thing I've heard for the last year and a half is just people feel very confused, but I think you've really, broken that down and explained all the competing forces that have been at work. So there was, I think there were a couple of comments asking you about GIST, and I think you've answered that and kind of gone over that. There was one question early on that said, what do we do about some of the people who do have those letters after their name, MDs, PhDs, and whatnot, who have been opposed to the vaccine or have been opposed to masking, and are putting themselves forward as trusted sources? Do you have any thoughts about what to do about that phenomenon?
Yeah, I mean, it's easy to say trust science. Everybody does, including the people who are dismissing the claims of mainstream science. And they're not doing it by saying, I'm dismissing the claims of science. They're saying, I'm using the good science. I've got sources too. So this is a doctor who says, this is a person at that reputable university who says, et cetera. The first thing is to not ever adopt the tone of the person I showed you in the last video. First, you wouldn't want to have the profanity anyway, but a tone that suggests that I know and you don't is counterproductive in any human communication experience. And so to the extent that there are people with alternative points of view who carry credentials, the question is, well, let's look at why they think that. Let's take seriously what is the source of their evidence, and let's see if you and I, and if they're in the room, if they can come to some things that we will agree to. So is there evidence other than the evidence that's being offered? And let's look at the evidence being offered, and let's look to the bottom line and see, is that characterizing it the same way I would characterize it if I read it? Let's see, in other words, if we can find a way to adjudicate back to how did they get there? How do I get there? Thinking that the people who are actually watching the exchange are the audience you're trying to persuade. And what you're trying to say to the audience is, those in the medical community, the scholarly community, are open to examining alternative interpretations. They're open to examining available kinds of evidence. What are the common standards that we can use to determine when we disagree about something, which one is the better interpretation? So getting back to the criteria is very helpful. Let's go back to the hydroxychloroquine, because that actually showed you people with medical degrees, they had MD behind their names, appearing in channels saying, I used hydroxychloroquine on my patients and I have 100% success. There was also a lot of anecdotal evidence, that is hearsay-based anecdotal evidence saying, I know a doctor who's using it and has a lot of success. There was also a lot of, I had a friend who used it and had incredible success. So a first question is, well, can we find who it is, where they are, and how we know that it was hydroxychloroquine that meant that they got well, as opposed to something else? Were they taking dexamethasone, for example? What else were they potentially taking? Were they taking remdesivir? Not a good idea to take remdesivir if you're taking hydroxychloroquine, but nonetheless, were there other things? In other words, what's the principle we're looking for? Were there confounding variables? Are there other things that account for the outcome? Then we want to say, well, how many people who get COVID recover? A reasonable number actually do. So how do we know the person wasn't one of those who was going to recover elsewhere? Now, what we're trying to do is to say, how would we know if hydroxychloroquine produced the outcome? If you can get people to grant that, well, yes, that there could be problems if there were other things being used. Some people were going to recover anyway. Then you would want to ask, so how would we know if it works? Well, we'd have a control. We'd have comparable people with a control. Some would, some wouldn't. Okay? We would have comparable dosing of the hydroxychloroquine across all those who do, and no hydroxychloroquine across those who don't. And how, so you begin to walk through, how would you get rid of those problems? You come up with, you'd like a randomized placebo-controlled double-blind clinical trial. If you say that, you'd say, well, then we probably should wait until we get that before we decide, because we can't really know because of all these other problems. And there's always the concern, and we knew this with hydroxychloroquine, that you could get heart problems from hydroxychloroquine. We knew that before. So we've got to figure out, are the risks and the benefits, balancing in favor of the benefits, if it's going to work, and then where is it going to work? So getting back to, I'm open to all available evidence. How would we know what's the best evidence? Finding the common ground and then stepping back into the debate is the first move that I would use. My first move would not be, well, they're wrong, because science says, because they're carrying, as the questioner points out, they're carrying a science credential in. But you wouldn't want to do that anyway, because it's a bad rhetorical move. So that's how I'd start the move. And also being willing to say, we don't know yet. It is being studied. I also would wish that we would have in every journalist's hands who's going to ever cover human treatment intervention science, a chart that says, over here, you've got the anecdote. Over here, it is somebody thinks this happened. Now, a person probably is real, but somebody thinks this happened. Then you've got systematic forms of observation. Observation is a way of knowing. Then you've got experiments, which try to start to get rid of the confounding variables and start to be systematic about trying to put all the protections in place. And then over here, you've got a lot of those clinical controlled trials that come to the same conclusion. And then you've got a systematic review that says that. If you can start by saying to the journalist, when somebody comes up with the medical study that says hydroxychloroquine works, and it's an observational study with a small sample, you want the journalist to say to the audience, if you're going to cover it at all, and in anxious times, you're probably going to cover anything that says there might be a solution. You might probably want to say, but this is very early, and this can't yet tell us whether or not this effect is real. So the journalist doesn't treat every study as created equal. Journalists got very confused through the hydroxychloroquine debate, because the first clinical trials were equated with the observational studies, and they were equated with what amounts to a form of doctor testimony. I've used it and it's worked. So that's a second solution I would put in place. It's basically understanding how science can know with surety, what strength of evidence. That's very helpful in clarifying debates too. One also has some arguments one can deploy once the behavior is already in place. We've got the strongest argument you can make for this, that the vaccine is safer than getting the virus right now. Because we've had hundreds of millions of people taking the vaccine. So when Nicki Minaj tweets to her 23 million followers that a friend of her cousin's has been spurned almost at the altar by his former fiance because his testicles were swollen as a result of taking the vaccine, the first thing you can say is, why, what a terrible thing to have to happen for someone. I'm so sorry, but if that happened to someone, that would just be horrific. You know what else could cause? You know what could cause swollen testicles? One of the things are sexually transmitted diseases. I'm really concerned. Perhaps that person has a sexually transmitted disease and they're confused and just got the vaccine a few weeks ago, now have a sexually transmitted disease, and faced with a fiance, are probably not that comfortable saying it might be a sexually transmitted disease, probably be more comfortable blaming it on a virus. Sometimes people confuse temporal association with causality, because something happened after, they blame it on something that happened before. Well, something that happened before may have been unprotected sex with an infected partner. Now, I wouldn't go there online, but I'd go there if a friend told me that anecdote. Then secondly, I'd say, well, let's see if they can find the person, because we need to find out, did the vaccine do this? But, we've had hundreds of millions of people who've taken the vaccine, and you think this would be the first time one would ever have seen this, including tens of thousands in clinical trials? Roughly half of them were men. And if that had happened to a man, don't you think he'd report it? Well, I certainly would think he'd report it. So you can start to say, well, what's your common sense telling you? We would have found it by now if it were happening. Then you get the Trinidadian health officials who searched Trinidad and couldn't find the person, who say, well, as far as we know, the person isn't there. Okay, so, and then Dr. Fauci says there's no mechanical reason. What he means is there's no plausible biological mechanism, but he's speaking extemporaneously, as we all do, and not grabbing the right vocabulary at the right time. No plausible biological reason why it would happen. So all of those things need to come together in order to counteract that as quickly as possible. So there are responses that are available to us if you mine the moment. But the one I want everybody to mine is hundreds of millions of people have taken this vaccine. What's the likelihood we wouldn't know of a side effect right now if it were actually there? I mean, statistically, it's possible, but boy, it's highly, give me 85 highly's unlikely.
Well, great. Thank you so much. This brings us to the end of this session. We so appreciate you taking time out and sharing all this great information with us. Just to observe in the chat, so many kudos, really love the presentation. Everybody's very, very excited by what you shared here today. So thank you so much. For those of you who are staying with us, we are just going to take a couple-minute break. At 2:50, we will start our closing session. So thank you so much, Kathleen. We really appreciate all of this great information you shared today.
And say hi to my friends at Maryland.
I will. So everyone else stay online. We will be back in a few minutes for the closing session. You don't need to go to another link. You just stay right here. We'll start in about 3 minutes.